talking about anemia. Anemia is defined as a reduction of hemoglobin concentration of red blood cells, RBC, volume below the range of values occurring in a healthy person. In this table, you see normal level for hemoglobin for each age group. For male and female. And you see normal level of hemoglobin, hematocrit, and mean corpuscular volume. Causes of anemia is continuous with low or middle incomes. Each of them are important. You see, the first one is genetic hemoglobin disorders, the second one is nutrition, and the third one infection diseases. They can cause anemia just by themselves, but sometimes they can be continuous and cause anemia with sometimes we can see a patient with thalassemia and for example vitamin B12 deficiency, and we see that he will have anemia. What's about classification? The first one is pathogenetic classification. We see anemia due to blood loss, post-hemorrhagic. It can be acute and chronic. And the second one, anemia due to impaired red blood cell and hemoglobin formation. It can be iron deficiency anemia, iron distribution anemia, and iron saturated anemia associated with impaired synthesis, megaloblastic anemia associated with impaired DNA synthesis, hyperproliferative anemia, anemia associated with bone marrow insufficiency, metabolistic anemia, and erythropoietic anemia. What's about morphological classification? We see this change with blood cell. What's happening? Microcyte anemia, whereas we see MCV, that means volume of erythrocyte. MCV, more than 100 microns. Diameter, more than 8 microns. That means we see megaloblastic anemia. It can be, we can see it in vitamin 12 deficiency anemia, folic acid anemia, congenital disorders of DNA synthesis, and others. The second one is non-megaloblastic anemia. That means when we see not changes, we haven't seen changes of MCV. Acerated erythropoiesis with myxedema and others. The second type of classification is microcytic anemia. Oh, sorry, here's not S, here's C. MCV is like as of this point. MCV, more or less 18 microns. We see this situation in iron deficiency anemia and disorders of hemoglobin synthesis. normocytic HCV 8199 microns. We see it in recent blood loss, significant increase in plasma volume, hemolysis, EC, infiltrative changes of the bone marrow, endocrine pathology, and virus-forming diseases. What we see? You can see in this picture changes of red blood cells. Anemia classified for the cell size: microcytic and microcytic. What's about hemoglobin classification? Normal, hypo, and hyperchromic. So that means how is it colored? Hypochromic, that means is erythrocyte less hemoglobin, and hyperchromic, that means it's a lot of hemoglobin in erythrocytes. They are purple. They are pale. They are pale. By hemoglobin concentration: normal chromic anemia, erythrocytes with normal hemoglobin content, and hyperchromic anemia, red blood cells with reduced hemoglobin content. What's about color classification? Hyperchromic anemia, that means a color index below 0.85. It can be iron deficiency anemia, iron distribution, iron anemia, febrile anemia, or thalassemia. The second type is anemia normochromic. That means color indicator is 0.85, 1.05. It can be anemia with chronic kidney diseases, hypo and aplastic anemia, anemias in malignant neoplasms and hemoblastosis, anemias in systemic connective tissue diseases, and hemolytic anemia. And the third type is anemia hyperchromic, whereas color index above 1.05. There are B12 deficiency anemia, B12 atretic anemia, and folic acid deficiency anemia. You can write this information. What's about regulation of erythropoiesis? I think you remember that all cells are produced in bone marrow. And when you go taught to a teacher about pathogenesis of anemia, well, first of all, you should tell about erythropoiesis. The hormone erythropoietin is an important factor of stimulation the synthesis of red blood cells or erythrocytes. Erythropoietin is a humoral factor in changing erythropoiesis in response to tissue hypoxia. Erythropoietin is produced in the kidneys, and the following substances are especially important for maintaining the blood system. For example, vitamin B12, folic acid, and iron. They are important for the synthesis of cellular DNA and hemoglobin fraction. In this slide you see regulation of erythropoiesis. You see what's happened. First of all, we see a person. If something's happened and we see low oxygen level in the body, reduced oxygen carrying capacity of the blood, causes by hypoxia, decreased oxygen availability to the blood, increased oxygen demand from the tissue. And the next step, we see that kidneys secrete the hormone erythropoietin, as like as I told in the last slide. What's happened next? Erythropoietin stimulates and changes erythropoiesis in the bone marrow. And we see when that more red blood cells are produced in the bone marrow. And in result, we see increased red blood cells count and increased oxygen carrying capacity of the blood. And after that, we see normal oxygen level in the body. What's about iron? Iron functions. Iron is an important component found in hemoglobin and myoglobin, muscle protein, and enzymes. Iron serves as a carrier of oxygen and electrons and acts as a catalyst during oxidation and decarboxylation. this slide you see ferrum daily requirement, and you see these changes of needings for each age group. For example, for infants from 4 months old, up to 1 gram for 1 milligram. Children from 2 to 10 years old, you see that they need 0.51 milligram per day. Puberty period 2 milligram, man 1 and 1 milligram, woman 2 and 4 milligram, and pregnant women 2 6 milligrams per day. For example, if you are a healthy person, healthy man, if you need to have a daily normal per iron, if you want to have it by the food, so you should to eat a truck of apples, or you can take you can drink vitamins, vitamin complex, multivitamins, and we're talking about this for the next slides. Sorry. Iron absorption. Iron is absorbed mainly in the duodenum and upper ileum. A balanced daily diet contains 10-20 milligrams of iron, but only 1-2 milligram is absorbed. You see, it's just 10% from the daily diet. It's very small percent, very little percent. There are 2 types of iron in food: heme and non-heme. I hope you remember this from the 2nd year of your study. You taught about this in normal physiology. What does it mean, heme iron? Only a small part of dietary iron is heme, about 10%. Heme iron is well absorbed and mainly found in meat products. What's it about non-heme iron? Food contains most iron very heme. Seems like 19%. Non-hemelic iron is mainly found in vegetables, eggs, and milk, and varies in the form ferrum 3+. In pathogenesis on the classes, you will talk with your teachers about ferrum 2+ and ferrum 3+, and about pathogenesis of iron, of metabolism of iron in the body. What's happened with ferrum 3+ and what's happened with the ferrum 2+. Iron transport. Transferrin is the only protein that carries iron. Remember this, transferrin. When we were talking about laboratory tests, you should remember about this protein, transferrin, because we can test it and understand, has your patient iron deficiency, anemia, or he hasn't. In principle, all cells have transferrin receptors, and iron uptake by cells is determined by the number of transferrin receptors. What's it about iron depot? You see here some depots. The first one. Iron reserves are mainly in reticuloendothelial system, the reticuloendothelial system of the liver and in the bone marrow and spleen. So that means the first depot is reticular endothelial system, liver, bone marrow, and spleen. The second one we see two proteins. Ferrum is a soluble protein and hemosiderin, forming an insoluble complex with iron. Degraded ferritin, it means biological analogy of rust. Iron recycling. Most of the iron entering the body is used to synthesize red blood cells. Transferrin bound iron circulated in the blood plasma and is captured by receptors located off the surface of the cells. And when hemoglobin is incorporated into the protoporphyrin structure, iron ferrum 3 plus is reduced to iron 2 plus. You see this information, I told you about this, and you should tell to your teacher this information when he will task you about iron circulation in the body. You can write this information. Iron deficiency anemia is polyetological disease resulting from a decrease in the total amount of iron in the body. Why? Because we thought that we have iron deporting, hemosiderin, transferrin, deporting in the liver, bone marrow, spleen, and we should have a longest time with disease to have an anemia to decrease level of all of these deports. So once again, iron deports. The circulation found. There contains content in erythropoiesis. The second one is transport found. Transferrin, we see transferrin, protein, transferrin. Reserve found. Content iron in the depot in the form of ferritin. Liver, spleen, bone, and brain. And functional found contains iron in myoglobin, and enzymes. Here you see with bands, with points, and you see iron deficiency anemia. We have changes to each of these the points. The first one you see circulation found, this point. The second one is transport found, this band. Reserve found, this band, and functional found is this band. That means if your patient has a pre-activated form, reduced levels in the brain, the last one. If you see a latent form, that means if you decreased level of iron in these bands, and iron deficiency anemia is when his level of hemoglobin is decreased. You see this information in the text, you can write it. And intrapartum caused in the development of iron deficiency. Toxicosis and chronic diseases, second half of pregnancy, when it breaks function of the placenta. Babies with low birth weight and pattern. Early and late cord ligation. Bleeding in childbirth. Causes of development of IDA in pregnant women. Negative balance of pheromone in the body. Insufficient intake. Criteria of anemia in pregnant women. For what we need it? You should understand what will happen with a newborn baby. Hemoglobin less than 110 hemoglobin per liter in the first and the third trimester. Hemoglobin less than 105 hemoglobin per liter for the first second trimester. Postnatal cases, causes of development of iron deficiency. Artificial feeding, low consumption of meat, the bioavailability of iron decreases, leading an increase in the content of phosphatases, oxalates, tannins, and calcium. Increased needs, repeat growth in infancy, puberty, low and high birth weight. Postnatal cases, once again, excess loss, intensive desquamation with epithelium, bleeding from gastrointestinal tract, nasal ureter, gay invasions, and disruption of iron transport, reduction of transferrin level in hypoproteinemia. For example, in nephrotic syndrome, nutrition deficiency, impaired protein synthesis, liver function, and malabsorption syndrome. In this slide you see normal levels and levels for the each decreases. You can write this. What's about clinical manifestation of iron deficiency anemia? You will see siderepenitic syndrome. You will see what kind of clinical signs. Pallor and dry skin, fragility of nails, is like a scalania, hair loss, atrophy of receptors and during of the tongue, testy of prevention, angiostomatitis, lack of the appetite, dysphagia. Esophagitis and epigastric pain. You see in these changes in sideropenia, it's very dry. It's very dry. What's about glossitis? You see these changes. It's normal and glossitis in anemia. Coilinum changes with the nails. And anemic syndrome. Chronic fatigue, destruction of attention, degradation of performance, head chest, tinnitus, weakness, fatigue, sleep disturbance, hypotension, and tachycardia. What's in about visceral syndrome? From the gastrointestinal tract, we see subtropical and tropical and tropical gastritis, colitis, lack of appetitis, and others. From the hepatobiliary system, the formation of fatty hepatosis. On the part of cardiovascular system, anemic myocardial dystrophy and others, and on the part of central nervous system, we see loss of memory, ability of to concentrate. Secondary immune deficiency syndrome, proficiency to chronic inflammation, frequent infection, and inflammatory disease. What's about diagnosis of IDA? We see reducing of content of hemoglobin, more or less 110 hemoglobin per milliliter. Normal or reduced red blood cell count. Reduced CPU, normal or reduced number of reticulocytes, increased of ESR, increased erythrocytes and anisocytosis severity index, RDW, microcytosis, we talked about this, NCV volume, reducing of average content of hemoglobin in the erythrocyte, MCIH, concentration of hemoglobin, H concentration, and the decrease in the average concentration of hemoglobin in erythrocytes, hemoglobin concentration, reducing the content of ferritin and reducing of ferrum serum. Criteria for the diagnostic: reduced serum less 12 millimole per liter, increased total iron during capacity more than 69, the percentage of transferrin iron saturation more than 17, hemoglobin content below 110 and below 120 grams per liter, over and less age 6 years old. What's about treatment? The say daily total dose of 3-6 mg per kilogram of element iron in the divided doses as adequate, with a higher dose used in the more severe cases. What's about drugs? First Aurexia, gained USA Food and Drug Administration (FDA), and we see that each tablet of ferric citrate 1 gram as equivalent to 210 milligrams of ferritin iron, and in the 2013 year, the FDA approved the ferric carboxymaltose injection, injectafer, for the intravenous treatment of iron deficiency anemia. What's about traction filtration? Iron preparation of the dose of which is calculated based in content of iron, atomic iron. The first 3 days, we should take 50% of a dose. Monitoring of laboratory parameters after 17 days, we see hemoglobin, and every month you should see another test. Reception of maintenance dose after normalization of indication, and the total duration of treatment is 4-6 months. You see in classification of drugs that continues firm. High dose iron, that means more than 100 milligrams of ferron, sorbifer, durex, metylferrum, ferrumlir. For medication contains medium doses 40-60 milligrams, phenyles, ferulatum, .HMA, and ferrofargamma, and low dose iron, more than just 10 milligrams of ferrum, Theraplex. These drugs for Europe part of this continent and for USA. I think that you saw these drugs in your countries too. You can write for me what kind of drugs you know, or what kind of drugs you're using in your country. Please write it. What kind of drug and country. Iron preparation. Sorbifer durex and multiferry, and for the parenteral using we should take venofer and ferrumlec. Anemia caused by vitamin 12 deficiency. Vitamin B12 is not synthesized by the plants. Produced by bacteria and several types of molds. In humans, vitamin B12 is found in the colon, but it's not absorbed. Which food we get 5-15 micrograms of vitamin B8. The content of the body of vitamin B12 3,000-4,000 micrograms. The 15% contained in the liver. Daily loss of vitamin B12 is 1-4 micrograms. The exchanges of vitamin B12 in the body. Daily need of B12 is 2-7 micrograms. We can see vitamin B12 coenzyme, its metabolism of catalysis of the process, or of transport of folic acid to its active form, and B12 vitamin coenzyme, dioxydenacylcobalamin is necessary for the normal metabolism of the main neural fibers. What's about consequences of vitamin B12? Multiple pregnancy, chronic hemolytic anemia, multiple myeloma and others neoplasm, myeloproliferative diseases, and thyrotoxicosis. What's in about foods? Veganism, and we see about stocks, cirrhosis of the liver, violation of transport of vitamin B12, the absence of transcobalamin too, of the appearance of antibodies to it. What's in about clinical picture? Characterized by a triad of symptoms. The first, violation of the digestive tract, violation of hematopoietic system, and violation of the nervous system. What's happening with blood? Reduced hemoglobin red blood cells, hyperchromic anemia, really normochromic. Blood serum increased of indirect bilirubin. We see hemolysis of erythrocytes, and iron is normal or increased. Bone marrow metabolitic type of blood formation. You don't answer formal questions, so it means you don't listen me. Okay. The treatment: elimination of cases of deficiency, nutrition, deworming, treatment of gastrointestinal diseases, and in the presence of antibodies to internal factors. Glucocorticoids are effective. What's about B12? Normal. Children up to a year, 5 micrograms per kilogram for a day. After the year, 100 to 200 micrograms for a day. Teenagers, 200, 400 for a day. Enter one time per day, 5-10 days. When we see 2-4 weeks before normalization hematological parameters. And with neurological symptoms, you should take to your patient 100 cyanide grams day in the 2 weeks. Criteria of treatment efficiency. Reticulocytes decreases from 3-4 days. Maximum rise for 6-10 days. Normalization of both marrow blood formation to the 20th day. Normalization of the peripheral picture with blood from 7-10 days. Full recommended securing for 6 weeks. And reduction of neurological symptoms from 3 days.